Good morning, everyone. Thank you for joining us for Collaborating at the Local Level to Serve Veterans and Their Children, presented by CSF President Sid Gardner.
Thanks very much. And let me start out by thanking Melissa Lujan and Jonathan Withers, our staff here, who have been putting this together, as well as Mary Ellen Salzano, who was in touch with a number of those of you participating, and using her extraordinary national network has gotten word out about this webinar. Our organization, as some of you know, but not all of you perhaps, Children and Family Futures is a nonprofit organization based in Irvine, California. We work with federal funding, but I should emphasize that this presentation is being made on behalf of Children and Family Futures, a nonprofit, and does not purport to speak for any of our funders at the present time. We work with veterans activities in a number of ways. We're part of a national conversation with a number of organizations working with veterans, and as you'll hear, particularly with the issue of veterans' children. That's the part of this issue that we've been most concerned with, and that's what we're going to emphasize today. Let me start out with an overview of what we're talking about today. I want to make sure that we understand the problem, which we frame as two issues: children who are invisible to the system, and we'll explain what we mean by that, and links to services that aren't as strong as they could be. We're going to talk about the numbers of children and veterans, the needs, in particular the needs of children who are affected by their parents' deployment, the networks that some of you are already part of, and the potential for strong collaboration at the local level, some of the barriers to collaboration, and a checklist of collaborative tasks. That's our agenda for the day. Let's begin with making sure we know who we're talking about. We make a distinction between active duty service members, knowing that over 2 million of them by 2014, the projection is 2.4 million in total will have been deployed, some, as you know, with many deployments. We make a distinction between active duty service members and veterans, and 40% of those who served in these recent conflicts are now separated from service. We make that distinction because, as some of you know well, the availability through the Defense Department of a range of family services for service members on active duty is very different from the availability of services to the families of veterans. And that's the critical distinction that we're going to make throughout this presentation. About a third of those veterans who are separated from service are married, half have children, about 2 on the average. But one of the real diagnostics of the problem is that there is no current figure, no authoritative figure, for the total number of children of separated veterans of recent conflicts, or for the children who are affected by family disorders that affect children as well as veterans, such as post-traumatic stress disorder and substance use disorders. Now, in a minute, you're going to see an estimate in a graphic that I'm going to show you, but it is just that. It is a very crude estimate. These are children who are not visible to the system because we don't have the number and we don't have the services available. So who are we talking about? I've just told you 2.4 million. That's the large circle. Those that are separated, the 40%, 1.48 million. Children of veterans is the estimate that we derive from the number that are married and the number that have children, averaging 2 children each. And then 30% of those veterans come back, we are told, by a number of studies with trauma or substance use disorders. That leads to an estimate, again, a very crude estimate, that over 350,000 children of veterans are affected by their parents' trauma or substance abuse. Now, it's helpful to compare that number with about 250,000 children who enter the foster care system every year. Those children are known to the foster care system. They're logged into those systems. They're reported to the federal government through state and federal mandated reporting systems. We know a good deal more about those children. We call these children of veterans who are affected by their parents' trauma and substance abuse invisible because they are typically not identified in those systems as such. As you know, separated veterans have access to Veterans Administration Service from the Department of Veterans Affairs. Approximately a third of them do access health services from the VA. About a quarter in rural areas, however, reach out and access non-VA mental health services, and 45% of them receive health services from non-VA sources. So going to the children of those veterans, they are not eligible for any services unless their parent is seriously disabled or homeless. As a result, the VA cannot meet the needs of these families with its own resources. That's not finger pointing at the VA. In fact, it's saying the VA needs help. And the reason we're having a webinar on collaboration at the local level is that the help needs to come from state and local public and private agencies. It's the partnerships, it's the networks, it's the collaboration in support of the VA as the VA identifies those separated veterans who need help because of the family of the diseases that affect families, including substance use disorders and trauma, and that's the help that we're talking about when we talk about collaborations. 30 to 35% of separated veterans, the best studies we have tell us, show symptoms of trauma or substance abuse. These are family disorders. They affect children, they affect their learning, their emotional stability, behavior, and the likelihood that children will adopt risky behaviors as they move on into adolescence. So what these children need, it becomes clear when we look at the studies of the impact of deployment on some children in some veteran families. What these children need is early identification and screening. We need to know who they are and where they are. They need substance abuse prevention services because that's a family disease. You can catch that genetically from parents and grandparents, the disease that goes on into further generations. And finally, they need mental health services that aim at the social and emotional stability that they may be exhibiting in schools, in preschools, or in other settings in their community. Because we're in a time in which resources and budgets and cutbacks and a whole host of financial issues are on the national table, we sometimes tend to say, well, these are resources issues. This is one, in our view, that isn't a resources issue. It's really a question of values and ethics. Should children whose parents deployed on behalf of the country be harmed or made more at risk as a result of that deployment? If the answer to that is no, then we need services, and developing those services that are responsive to the needs of those children is one of the most important tasks of caring for veterans and their families. If you agree that no child should be more at risk than they were before their parents deployed, that we should honor their parents' service and the resilience, and we're going to talk a little bit about resilience, the resilience that that family shows sometimes. We should honor that by making sure that any needed services are there for those children. Then that's not a resources question. It's a question of values. We'll talk about how to carry that out. The time frame is also important. We're winding down the conflicts that we've been involved in since 2001, the most recent Iraq-Afghanistan conflicts. But when you look carefully at veteran spending, it does not stop when people come home. In fact, it goes on for a 30 to 50-year time frame. And then when you add what we know about the long-term effects of adverse childhood experiences, those also have 50-year and longer effects on health, mental health, and family stability. So this is a long-term cost. This is not something we fix as we downsize the Army, as we downsize our overseas commitments. The effects of some of these deployments on some of these families and children will be long-term. And we need to realize that we're planning for decades in the future, not just coming up with a short-term services fix with a few projects. We think that you can take a very, very complex set of issues and boil them down to three broad themes. We've introduced each of these in a general way. The first question is, how many children of recent veterans are there? And until we have that number, as we're going to say later, you can't coordinate what you can't count. You can't serve children that you can't count. And so that fundamental question of how many kids are we talking about, how many in total, how many are affected by their parents' deployment, in ways that may increase the risk to the children? That's question one. Once you know that, you can move to asking the question about needs. What services and supports do they need, given their parents' effects from eligibility of most VA services as a result of deployment? And finally, there's a question about network. How can we make networks, collaborative, coalitions at the local level that respond to the needs of these children? Now, we know from looking over the associations of some of you on this call that some of you are involved in outstanding local networks already. We don't make this presentation assuming that nothing is happening. We know that in California and Texas and Minnesota and North Carolina and around the country, there are some excellent local networks that are already doing this work. So we're talking about building on the strength of networks that's already there, not assuming that there's nothing out there. But we've heard from enough of those networks that they need some additional thinking and support for their local collaboration to feel that the webinar is worthwhile. And these are a few of the efforts that are underway. Within the VA, a new set of grants, the Section 304 grants, are available. We've got the housing and supportive services there. We've got model programs that provide therapy in some medical centers and veteran centers that are providing family therapy that includes not only spouses but also children. Not a majority of cases, but in some cases that service capacity is there. School districts in a number of places around the country, and we know there are national and statewide coalitions that have worked on school districts that have identified and served children of veterans, and collaboratives at the local level that have indicated. Now what I want to pause and emphasize here is the distinction that I made when we started out between active duty military families and veterans families who are separated. Many of these collaboratives, many of the school district's efforts are doing a superb job of working with active duty military families in parts of the country around military bases and deployment areas where there are large concentrations of active duty military families, where the Defense Department services, the child care, family advocacy, school districts, a host of programs available to active duty service members are involved in collaborative activities. Those are laudatory, needed, and important. They don't, in many cases, however, have as great an emphasis on separated veterans and their families as they do on active duty. And with 40% of those involved in recent conflicts having separated completely from the service and no longer being eligible for or enrolled in TRICARE Defense Department programs, that's why we're making the emphasis that we do upon veterans. So those current efforts do focus in some cases on veterans, and in others, their major emphasis for some very good reasons is on active duty service members in the local communities and in the state. The barriers to local collaboration involves, again, the fact that these children are invisible. When we do interviews and talk with people at the local level, often the first question or an early question is there a box on the form that identifies that this student or this family involved in child support, child welfare, mental health services is a veteran? And in many cases there is no such box, there is no such identification, and so the children in effect become invisible. An additional barrier is that civilian agencies sometimes don't understand military culture. We talk about cultural competency, and we usually mean ethnic, racial, linguistic, gender. There's a host of kinds of cultural competency. Military culture has its own important lifestyles and ways of thinking about life and responsibility and discipline, and that's not always inherent in civilian agencies who want to be helpful to service members and veterans. That's something that has to be learned. Some agencies have done a superb job of hiring and training peer counselors who are themselves veterans who come from that culture and can bridge that in the same way that agencies have done that with ethnic and linguistic minorities. We also have a barrier when we fail to build upon the strengths and resilience of military families and veterans. If we only see veterans who are having problems with trauma and substance abuse as deficits, as problems. We forget the extraordinary resilience that some of them bring. The experiences they've been through strengthened them, strengthened their families back home in some cases, and building on that strength is as important as diagnosing the problems of those families. That needs to be a part of the training curriculum. Sometimes it is, and sometimes we tend to overemphasize the deficits in those families. What does a local collaborative need to succeed? We spend a great deal of time with collaboratives around the country in court systems, child welfare systems, substance abuse at the local level. These are some of the lessons that we would underscore in thinking about collaboratives in general, and also about veterans collaboratives in particular. First of all, if you don't have the people in the room who serve children, youth, and families, you're missing some players. Second of all, as we've already indicated, a box on the form helps you know who's in your caseload who is a veteran. Third, an inventory of local public and private services. If you don't know what's out there, both in terms of explicit programs that are already serving veterans and programs that could or should be serving veterans, then we're going to miss some of the important ways that we could expand the services to veterans and their families. And finally, we've got to work back on that big question of the number. You can't coordinate what you can't count. If in your city or county or state, the total number of families needing help and the children associated with those families is an unknown, then it's going to be very hard to target resources on those particular families. We also talk about levels of collaboration. Collaborations at the local level, and for that matter at the interagency level at state and national levels, go through stages, just like the developmental stages of a child. Child crawls around for a while and stands up and starts walking and toddling, and then before you know it is running and disappearing. Those stages of collaboration move from people just sitting around a table exchanging information. What do you do? Who do you do it for? How are you funded? What's your eligibility? That first stage of getting to know you, exchange of information. And after that goes on for a while, we decide in many collaboratives, let's get a grant to work together and outstation your staff in my place, or train my staff to work with your agency through referrals, or to do something else together with external funding. And that's the second stage. And that a lot of collaboratives stop at that stage. In fact, they can get stuck at that stage in what we call projectitis, in which the project itself becomes the reason for the collaborative's existence. But the next two levels make clear that there are higher orders of collaboration where there's a real payoff. If your project takes outside funding to sustain it, then in effect, the rest of the system is saying to you, we will only do this kind of collaborative stuff if somebody else gives us money. That's why we say the third stage is redirection of funds. That's the point at which the collaborative has proven that we need to change the rules so that we can use existing funding more effectively for veterans and their kids. That's harder, but the payoff in terms of sustaining funds is much greater than getting another project grant or getting a project grant renewed. And finally, you move up to the level where funding is results-based and performance indicators, and watching whether, as we and many others put it, whether the needle moves overall. Once you know how many children of veterans there are in a school system or in a mental health system, or stated more positively, involved in local activities, local sports and recreational activities, you can watch their progress over time. That's changing the system because you're looking at all those kids and how they're doing. Stages of collaboration. It's important to know, and there are diagnostic tools that we and others have developed that enable you to ask your collaborative some questions and to do a self-assessment. We call it a collaborative capacity inventory, but it's a way of asking yourself, where are we? At which stage are we? A lot of collaboratives, recognizing they're at stage 1 and 2 and that there are other levels to go to, can think harder about the work of collaboration that lies ahead, rather than feeling satisfied that we've got a project, we've got a grant, work done. This this framework hopefully makes clear that there are challenges that lie ahead. There are also two different ways of seeing collaboration, and over time we felt it's important to emphasize both. The first is sort of the hard skill of numbers, data, accountability, matching resources and results. It's a strong emphasis on outcomes shared by members of the collaborative and outcomes that we make sure the collaborative buys into across agencies rather than having one agency and a bunch of other people sitting around watching. But that kind of accountability, that hard scale, has to be matched, we've found, with partnerships that are based on trust. And trust grows out of relationships that are built over time. Those are soft skills. They're about relationships, personalities, knowing how to work with people, knowing how to identify the champions who are your supporters in a collaborative and the blockers who, for reasons of turf or personality or for whatever reasons, may have trouble signing on to the collaborative. Both those skills are needed in a collaborative, and you'll find around the table in a good collaborative some people who are really good at the accountability stuff and maybe not as good at trust building and the social capital building that the soft skills require. And you need to have both those kinds of skills present. If you've got all accountability and no trust, then there's going to be a lot of finger pointing going on in a collaborative, and that's usually a diagnostic of problems. If you've got all relationships and process and talk, and no ways of measuring effectiveness, you can also have a rather ineffective collaborative in which everybody comes together on a regular basis but may not have ways of measuring progress that's made on behalf of the clients. And that moves us to thinking about some of the challenges that collaboratives need to overcome. We've talked already a bit about missing players. If you're talking about children and child-serving agencies aren't there, you've got some missing players. You may need to recruit the school district or the mental health system or private agencies that serve children, boys and girls clubs, and sports organizations who are involved and who may not yet be at the table. There's also a great tendency in a lot of collaboratives to talk about the activities of the agencies rather than progress of the clients. And so a show and tell version of what we did last month is what gets reported in a monthly meeting rather than whether the clients are getting better, whether there's progress for veterans and the children who are in the program. I've talked already about projectitis, defining progress as having a project and then getting it refunded. We use a military analogy. It's a little bit like invading Normandy and then digging in on the beach and forgetting that Paris and Berlin are the real target. Happily, we didn't invade Normandy that way. We went inland as quickly as possible, and the invasion itself was the beginning of something larger. We saw the larger system, the larger strategy, the tactics of invasion became less important over time than the large strategy of winning the war. Projects can be like that. They can become so time-consuming and so difficult to launch that we begin to define a small project that may serve 30 or 50 families rather than looking at the entire scope of the need in our community. And finally, we need to make sure that collaboratives know the difference between grants and what we call fair share funding. And that's a question of whether veterans and their families are getting priority in other agencies' caseloads. An example that's come up in one of the collaboratives we work with is child support. A number of veterans are affected by child support issues. And when we talked to the veterans involved in that, they said, yes, that's a problem. When we talked to the child support agency, they said, yes, that's a problem. But there weren't any resources set aside to deal with the particular issues of child support when the parent involved is 10,000 miles away, or dealing after he or she has come back with trauma or substance abuse or simply the lack of a job. And that priority in the child support caseload, priority as some of you are involved in the court system with veterans treatment courts, nearly 100 of them around the country now. That kind of priority can be as important or more important than pursuing grants. Collaboratives need to know the difference. between seeking a fair share of funding that's already in the community and going after grants from outside sources. That's one of the most important challenges that collaboratives run into. A checklist of tasks. I talked earlier about a diagnostic process, a self-assessment in which collaborative can ask, how are we doing? How strong are we in this area? How much do we have yet to do in another area? And these are some questions that we think are fair questions as of this moment for a collaborative that works on veterans issues with particular emphasis on children to ask itself, do you have an inventory of services that's kept current? Now, we've looked a lot at 211 systems and military one source and a host of systems that provide little books or checklists or online inventories of services, and those are all very helpful and well-intentioned, but that it's those last two words, kept current, that seems important. We've tested some hotline services that are no longer in service, or where the eligibility is quite narrow, which wasn't clear in a resource directory. So the question of whether the collaborative has an inventory of services that is kept current is an important test of how the collaborative works together. Second, do you track referrals? Saying we sent these veterans over to this agency doesn't really tell us anything about what happened to them. Making a referral without follow-up, in the view of some people, is a kind of malpractice. It's sort of getting them out of your building, getting them out of your caseload, and sending them over. Finding out what happened to them is tracking and monitoring whether the veteran really gets the service, rather than simply making the referral. The third question is, do you have local colleges and universities engaged in training, surveys of needs, evaluations of impact? The good news is the Defense Department, the VA, and other sources have funded a variety of organizations around the country. We're delighted to have an intern from USC School of Social Work who was formerly deployed to Iraq and knows a great deal about these issues. That's one example of a number of universities around the country who are working on training, who are doing surveys of the needs of veterans at the local level, some of whom are doing evaluations of whether these programs are effective. Reaching out to those assets can be an important way of supplementing what a Veterans Collaborative can do if those higher education institutions aren't yet at your table. Health coverage. To the extent that we're talking about children who may be affected by substance abuse or mental health issues as a result of their parents' deployment, this next question becomes very important because all over the country, health decisions are being made and will be made over the next 2 years about expanding coverage for mental health services, and decisions are being made about what services will be included. And the question becomes, are veterans advocates and providers present in those discussions? Are they raising the issue of need? Are they asserting the need for set-asides, for outreach to veterans and their children? Who's making those decisions, and to what extent are Veterans Collaboratives present at that table? Even in states where a decision has been made not to implement parts of the Affordable Care Act, the decisions are being made about how the federal government and other providers will be involved. Managed care agencies need to be involved. Efforts to establish health homes can definitely affect veterans. Having somebody who's involved in the collaborative tuned into these important multi-billion-dollar decisions about expanding coverage and services that will be included can be an important way of making sure that children and veterans themselves can connect with the health services and mental health services that they need. And finally, in some cases, we've already had a debate about whether programs for veterans should be exempt from cutbacks. The sequestration and the ongoing debates in Washington are mirrored by similar conversations in many states. Are veterans just another program? Are they just another group? Or do we have any kind of set-aside, any kind of priority or exemption from the cutback process that's going on? Those are tasks that a collaborative could be discussing. They may be as important as talking about individual projects at the local level. They raise important policy issues that are statewide and national, but they are about whether individual services and supports get down to the veterans in your community. and a collaborative needs to think about those larger tasks as well as working on the activities that they may be involved in at the project level. It's also important to remind ourselves, as I touched on earlier, that veterans and military families bring great strength to the tasks of reintegrating in their communities, along with all the challenges that they face. Veterans and military families come with a respect for authority, a sense of mission. They understand loyalty and teamwork. And in those families and among those veterans, building on those strengths can be as important in providing services as it is with any other client. If you view the client across the table from you as a pile of deficits, as a composite of problems, you're unlikely to be able to recognize those strengths. These military families and veteran families often have been through experiences that have built strength as well as posing significant challenges to them. And we need to make sure that we bear both those in mind as we provide those services through local collaboratives. In the future, in addition to the veterans that are now back home in our communities, the pending reductions in force are estimated to produce anywhere from 25 to 90,000 additional newly separated veterans. There's some speculation in the interviews that we've done that some of these, at least some of these, will be veterans who have been separated from service as a result of existing problems. And that means that the given number of veterans in your community may increase in short order within the next year or two as reductions in force and downsizing continues. Second, there's a risk of a loss of sense of urgency. Some people have alleged that the country from time to time has its own problems with attention deficit disorder as a nation. And as the conflicts wind down and troops return, we may move on to other issues. Some of those issues are going to be challenging for a long time in the future. And just because we're not reading headlines any longer as we wind down our commitments overseas doesn't mean that we don't continue to have the long-term challenge of dealing with veterans and reintegrating them into our community. Again, I've tried to emphasize throughout an important distinction between active duty service members who have access to a variety of Defense Department services and supports and separated veterans who are much less able to access services that they or their children may need. And finally, it's important to continue to work on the issues of training, identifying models that work, and making sure that we have staffing that's culturally competent and that understands military culture. There are some important resources that we'd want to emphasize. As Melissa said, as we started, the slideshow is available on our website. These are other resources. SAMHSA, the federal government agency involved in drug and alcohol prevention, as well as mental health issues, has a technical assistance center on military families. 0 to 3, national nonprofit organization, has done excellent work on military families. That's their website. At the National Association of Drug Court Professionals, the work on veteran treatment courts is available at the Justice for Vets organization, the Iraq-Afghanistan Veterans Organization, and the Veterans Administration system is also one of the resources. Let me pause now and try to respond to some of the questions that have been raised. Thank you for your questions. Again, please use the chat line. I've got one here about, it's a very good question. I'm going to read it out loud because I think it captures one of the things that we were trying to talk about. It's interesting to hear the comment says about the description of systems and organizations. I worry about assuming that sending children and families to therapists for, quote, mental health services, close quote, on the assumption that therapists know what to do. Do you have information about whether therapists or anyone else in your collaborative gives the family members, especially including the children, a chance to talk about the fact that the terror of knowing that a deployed parent could die or be severely injured is not something that could be analyzed away? I worry too about the showy public displays of having a displayed parent surprise a child by showing up in the school or at a sports event and having huge numbers of people witness the reunion when the child should not be put in that situation. It's a very sensitive question and an important one. I would simply, I can't point to a particular collaborative that does that so much better than others that I'd say it's a model, but I can say that the training programs that 0 to 3 and SAMHSA and other organizations have been involved in have been sensitive to the issues of children wanting to and not wanting to talk about these issues in a therapeutic setting. I mentioned before the availability of peer therapists and peer coaches that some children and family agencies have reached out to. The good news is that hundreds of veterans of Iraq and Afghanistan, including the young man that we're pleased to have on our staff, are being trained in MSW programs and other skilled training programs as professionals, and in some cases as paraprofessionals in community colleges as well, to be able to reach out to families and to communicate with children. More of that's necessary. The expansion of that kind of training that's sensitive to veterans issues is an important resource, but I'm not at all prepared to say that from what we know, that's done now at an adequate level of investment. It's a good and important step in the right direction. Very good question, and I think that it's well to remind us that simply making a referral for what's called therapy doesn't guarantee that the therapy will be effective or appropriate or sustained in a way that's positive. Phil Breitenbuscher, who's sitting in with us, who's the director of our Family Drug Court Project, raised a question about who can be the leaders of these kinds of collaboratives. We're familiar with collaboratives that are led by a set of co-chairs in which a decision was made deliberately not to have any one agency be dominant. Public agencies, school districts are involved as leaders in some. Universities, the collaborative that's involved in Los Angeles has been convened by USC School of Social Work, given its prominent role with the Center for Innovation and Research on Veterans Issues. Around the country, some have been convened by child welfare agencies or children's mental health agencies. It's more important that the right players be in the room than that the right convener be at the head of the table. But having said that, those of you involved in court systems know of the power and unique convening authority of a judge or a judicial commissioner, and we've seen examples of veterans treatment courts and other emphasis on veterans involved in the court system. The extraordinary work the VA itself does, reaching out to incarcerated veterans and trying to work with them, is one of the bright spots, I would say for sure, in the VA's activities, and that project has to be closely involved with law enforcement and the court system. So no one appropriate convener, but making sure that a convener who will stay the course, who has the authority to convene, and who is well staffed are all ingredients that we've seen be effective. Again, if you have further questions after reviewing the slideshow from our website or on reflection or after looking at some of these other resources, we'd be delighted to try to respond. You can reach out to me, Sid Gardner, at the cffutures.org. It's S. Gardner, S-G-A-R-D-N-E-R, at the address you can see on the screen, cffutures.org, or to David Barr, who is our intern, or to Larissa Owen, who staffs us and is a member of the California Military Service Reserve Organization. We'd all be happy to try to respond. We're looking forward to some conversations in Washington next month with national organizations about some of these issues, and a background paper should be available from that meeting at some point late in December or early in January. Thank you for your interest and your attention. Please let us know if we can be helpful in any further way. And with that, we'll conclude the presentation. Thanks very much.